This is my presentation entitled Global Perspectives on Primary Healthcare. And what I'm going to do is to talk about the historical perspective of primary healthcare very, very briefly, and then proceed to talk about 3 countries, Cuba, South Africa, and France, and then end with a few words on the post-pandemic perspective. Historically, I always date primary healthcare with the Alma Ata Declaration, 1978. But when the declaration was made, people were confused on how to implement it. And therefore, there was this controversy on selective primary healthcare versus comprehensive primary healthcare. You can read more about that. But selective meant they looked at programs and then they implemented that. And they were very selective. While comprehensively, if they wanted to approach it, was they looked more horizontally and tried to do integration across the system. But as you can see, they were struggling with this through the latter part of the 1970s. And then the MDGs in 2000, and primary healthcare. And I'm going to show you an idea of how the concept really evolved. And then, of course, there are the concepts of One Health, Sustainable Development Goals in 2050, planetary health, and then the post-pandemic situation. So when you think about it, this has been the evolving firmament or landscape of primary healthcare. And so this is a quotation from 1978. And this is Halfdan Mahler saying, primary healthcare starts with people, their health. Very nice, very visionary, but doesn't tell you how you're going to implement it. And then in 2008, 2 reports came out. There was the report on the social determinants of health, and then the revisited primary healthcare report. And I have a favorite quotation from that, which reads, "The mobilization of forces in society, health professionals and lay people, institutions and civil society around an agenda of transformation of health systems that is driven by the social values of equity, solidarity, and participation." Note one very important addition in this, or 2, okay? One is mobilization of all forces of society, and that means government and non-government, and the inclusion of the term health systems. Because as you know, in the year 2000, that was when the World Health Organization came out with an evaluation of health systems, for all countries. And I'll say more about that later. But you see, the values are here. And, these are the values that we keep repeating over these last decades. And when you look at that in terms of concepts into very, very specific themes, these are the 4 themes from the World Health Report, okay? Universal health coverage. In this case, really, this had to do with many of the financial reforms. And then service delivery reforms, and this has to do with implementing service delivery, human resources for health, health infrastructure, medicines, those building blocks of health, into a people-centered approach, which includes financing, and then including health in all policies, and to tie up all together, leadership and governance. So as you can see, these are the concepts around which primary healthcare revolves. But the question is, how do you implement that? How do you implement that in each specific context, in each country? And that's what this presentation will try to illustrate. So let's go to Cuba, okay? And I get this from a presentation of a Cuban himself, from this webinar that I attended, in February. Okay, I'm sorry, in September of 2021. Okay, look at Cuba. Okay, it's an island, population of 11.3 million. You know, when I was listening to the presentation, it's like the Philippines because it was once a colony of Spain. So provinces and municipalities, 168 municipalities, but really only 11 million people. That's only a tenth of our population. When you look at the map in a bigger graphic, look at some of the names. Okay, Santiago de Cuba, Guantanamo. You know, this is where, you know, the U.S. had their detention center for terrorists. Right? Holguin, Camagüey. I'm just showing this to you because I want to show you their populations. Okay, Havana was 2 million. Santiago de Cuba, you know, less than 600,000. Camagüey, less than 400,000. But if you look at that and you look at the populations, you know, they're like our provinces. Okay? And of course, our cities, with Havana with 2 million, you know, Quezon City is about 3 million. When you look at the smaller provinces and municipalities, what, 35 million? 35,000 population. So you can see it's very much like the Philippines. Now, what did they say about Cuba? And this is what this professor said, okay? There are what they call consultorios, first-level clinics for consultation with doctors and nurses, and regional polyclinics. You know, it's like our RHUs and regional hospitals, okay? And they talk about this primary level characterized by a general family doctor and nurse model, tasked to improve primary care. And to show a picture of that, this is it. You know, it looks like one of our RHUs. But they say that, you know, this is where the doctors and the nurses live. So they're immersed in their communities. And, you know, they're available for all of the people there who are sick and at risk. They make rounds to ensure that everyone receives vaccines, prenatal care, and they check on water and sanitation. You know, this is pretty much what our RHU and sanitary inspectors do, right? But from here, I was thinking they have many more of them in their municipalities. But their consultorios are also decentralized, like ours, okay? But you see, Cuba is a socialist or a communist country. And therefore, their system is largely public financed. And so they put a lot of money into their system. They produce a lot of doctors. In fact, they export doctors as part of their diplomacy. And so their system was also under pressure, and therefore they were talking about reforming the primary healthcare sector and upgrading it. Okay, this is what this professor was saying. And they were doing that because they also had to respond to COVID. And therefore, whatever it is that they reorganized, they said it was more effective to address disasters, epidemics, and extraordinary situations. And of course, you know that Cuba has been under economic blockade by the US. And therefore, they've had to be really very self-reliant. So their main issues, when you look at these bullets, you know, they're the same words that we use. Community involvement, intersectoral collaboration, you know, socioeconomic development, political will, epidemiological response. And they talk about a national health system, which is, you know, very similar to ours. You know, we talk about a national, you know, public health plan. We have the UHC law. And during COVID, you see, in September 2021, which is when this presentation was made, you know, they had already vaccinated 30% of their population. And they brag about the fact that they were able to develop their own vaccines. So this is really what I want to talk about in the second part about Cuba, that they had a very, very strong biotechnology sector, which they started funding as early as the 1980s. Okay. And because of that, you know, their labs were able to develop a vaccine. And in fact, they developed 5. And these vaccines that they developed were protein-based. So you don't need special refrigeration. They're different from the mRNA-based vaccines of Pfizer and Moderna, but they claim that it's very effective. And in fact, this is the director of the Vaccine Institute, Finlay Vaccine Institute, Dr. Vicente Verez. And he was saying that, you know, when Delta hit, they had vaccinated practically all their children because they have had a whole tradition of vaccinating children for years. And there's very, very high trust in government. And therefore, he was boasting that by November, they had vaccinated their children, there were 0 deaths. Whereas before they had their vaccinations, there were about 80 child deaths. And so this is the figure that they have in terms of vaccination. And this was early this year. And they were topping the list among countries with the highest vaccination rates. And this is a person being interviewed who was saying that, you know, they trust the Cuban system. And what this lady was saying, you know, she trusts the revolution in Cuba. And now Cuba's exporting their vaccines to other countries. The one blip here is they haven't shared all of their data, you know, to WHO about how effective their vaccines are. But other countries are buying them. And in fact, these are the countries they're exporting their vaccines to. And Iran has even joined them. Okay, so when you think of Cuba then, you've got a very, very strong primary care level. But on top of that, a very, very strong biotechnology sector that's able to produce vaccines. So that's one example. Okay. Let's move now to South Africa. Okay, this is the same conference, and this is a South African doctor. Now, when you think about South Africa, it's a different society. Okay, this time a population of 60 million. Okay, and a lot of them living in the urban areas. But you can see that a large proportion of their population are really very poor and living in informal settlements. And a highly inequitable society with a Gini coefficient of 63. Okay, the closer it is to 1, the more inequitable. So that's South Africa. And when you think of South Africa, you think of HIV/AIDS. Very, very high rates, both in men and in women. And in fact, they say in South Africa, you have a quadruple burden. You have communicable diseases, HIV being one of them, non-communicable, violence, so much violence there, and maternal and child mortality. And also in South Africa, huge HRH shortages. In fact, in 2004, the Minister of Health of South Africa led a resolution in the World Health Assembly that led to the development of the code for international recruitment, which was the work that I was doing there when I was with WHO. But South Africa also has a national health insurance scheme, and you know, they're still trying to work it out, but they're having to strengthen their whole health system, which includes HRH, health infrastructure, public hospitals. Now, these are the lessons that this professor talks about, but he talks about health system strengthening, HSS, before COVID. And he's referring to a project of the US, you know, the Centers for Disease Control, which tried to strengthen the health systems of South Africa, you know, in the early 2000s, using what they call PEPFAR funds. Okay, and they had to recalibrate their service provision to improve it, and they were deriving many lessons. Okay, from improving their system. particularly when COVID hit. And this is what they're saying. This professor was saying that for South Africa, he was making the case for stewardship. And he talked about stewardship to improve the functioning of all of their WHO building blocks. And when you look at it here in his slide, and I just inserted it, he talks about stewardship in the areas of, again, intersectoral collaboration, service delivery, given the plurality of providers. You see, in South Africa, they also have a public-private system. But the private sector only serves about 16, maybe 20% of the population. And the rest, it's all public. And the public system, like ours, under pressure to provide services to the majority of people who are poor. And also, only a small proportion of their people pay taxes to fund their national healthcare insurance, similar to our situation. And so that's the situation in South Africa. Okay, a highly challenged society in terms of their inequities, a lot of violence, a lopsided public-private system, very good health care for those that can afford it in the private sector, and a very stretched public sector. Let's move to France. Okay, now France, population of 65 million people. The interesting thing about France was that in the year 2000, when the WHO report on health systems came out and ranked the different countries' health systems, according to different parameters, which included health outcomes and responsiveness, France ranked number 1. Okay, and so France is very proud of their health system, and their health system supposedly is built on a national social health insurance system, patient choice, provider autonomy, okay, the health professional having autonomy to provide services, central regulation, and also a mixed economy of public-private. But the situation in France is, they say, the services in the public sector is equal to the services in the private sector and vice versa. And that gives for really a lot of flexibility for patient choice. But this is what I wanted to show you, okay? So a state health insurance that funds 70%, and then they have a voluntary health insurance system that you can top up. Of course, there's still some out of pocket. But see here, they have a coordinated healthcare system where you have a gatekeeper called a primary care physician for people 16 years and below. And through this primary care physician, you can get referrals to hospitals, specialists, other specialized care. Okay. So that's where you can see autonomy of your health professionals, but also choice by the physician, I guess, when he's talking to the primary healthcare physician. Okay. Now, this primary healthcare physician can be bypassed in a situation where, you don't have a primary care physician, and if you have consultations with gynecologists, ophthalmologists, and psychiatrists, you can even bypass the primary care physician and go straight to your specialists. Okay. But the interesting thing is here. Okay. So this is their system. And every citizen has what you call a carte vitale, just like a credit card. But as soon as you pay upfront, okay, the card is swiped, and immediately there's a notice to the central social insurance system, and a reimbursement is triggered immediately to about 70% to 100% of your costs. So you pay up front, but you're reimbursed immediately. Okay, and that's why the system works so well. But you have to up the payment. You have to pay give the payment up front. Okay, and this carte vitale, as you can see here, excuse me. As you can see here, The Carta Vital contains all of the information of the patient's health insurance, okay, and a microchip ensures interoperability. And you can also work it out so that the patient doesn't pay upfront, okay, but the social health insurance system pays directly to the providers, okay. So this is a situation where you have, let's say, pregnant women or long-term illnesses, okay. They don't pay upfront. The payment is just paid to the providers. So when you think of that, okay, the French health system, very, very strong coordination by national government, strong support from their health insurance fund, and you know, this IT connectivity that makes the system work. So those are three systems, okay, that will give you a perspective on primary healthcare in these different countries. But let me go to this slide now to remind us that really primary healthcare involves so many other things. And therefore, this concept about intersectoral collaboration is very, very important. And health is only one of these different pillars of the Sustainable Development Goals. And I don't really need to explain this at length. You know, you understand what this is all about. And therefore, I'll go to the summary and my concluding remarks. We've talked about Cuba, which is a mainly public sector health system with a community-based primary health care, very, very strong, but a very, very strong biotechnology sector. South Africa, an inequitable society, struggling with a public and private system that isn't working, you know, to the advantage of everyone. But it makes the case really for intersectoral collaboration and community engagement. And, you know, South Africa eventually did pretty well with COVID, okay? And France, a state health insurance system with an IT-enabled system, and of course, a very, very strong sense of solidarity within society. My last remark is this, you know, post-pandemic, when we talk about primary health care, really the challenge is to reimagine healthcare as social care that integrates care across very, very many sectors and has policies across all of those sectors. So I'll end there and we can open the floor for questions and discussion. Thank you very much.